Hi, I'm Dr. Gulani. Today I'm going to address your questions about keratoconus, which I've been teaching and performing for over 3 decades, having helped patients from all over the world. And it's very, very important that you understand that contact lenses is not a cure for keratoconus. Cross-linking is not a cure for keratoconus, and corneal transplants are not a solution for keratoconus. Understand this very deeply because a lot of patients fly to me and being told that these are the only 3 options they have and their life is now relegated to being visually disabled and dependent forever. Don't have to. For over 3 decades, I've been helping patients from all over the world who've come here with every severity of keratoconus and various surgical complications of keratoconus that they come to me with. Here's how I think. Join me. Let's learn. So keratoconus, having seen numerous kinds from all over the world, different cultures, different patients, and different stages of situations of keratoconus, I've divided them into very simple 3 categories. Category number 1, visual. Category number 2, structural. Category number 3, salvage. What does this mean? So visual are those keratoconus patients who can see with glasses, who can still see with glasses and very well. Structural are those who cannot see with glasses well enough and need specialty contact lenses to see, which may be hard contacts, scleral contacts, 3D print contact lenses. Salvage are those that even with contacts cannot see and have gone very far. Cornea is completely scarred, come down to extremely thin, and we'll talk about those cases. So visual, structural, salvage. That's it. Doesn't matter what kind of keratoconus you have. Don't waste your energy in trying to get diagnosed to the stage of keratoconus. More important thing is how to fix it. Correct? So if it's keratoconus, pellucid marginal degeneration, LASIK ectasia, keratoglobus, all these are ectatic cornea, meaning the cornea has herniated, and we need to control that and bring back your vision. Just remember that. So let's look at the anatomy. This is the cut section of an eyeball. Your cornea, instead of being a perfect dome-shaped cornea in normal people, becomes a cone. So keratoconus, kerato is the cornea, conus shaped like a cone instead of a dome. So that's the problem, because you're not looking through vision through a windshield that is warped, that is abnormal in shape, very steep. And the characteristics of keratoconus is your cornea becomes thinner than normal. It starts bulging, meaning cornea becomes steeper, has high irregular astigmatism, and now it's difficult for you to see through this angulated cornea, if you may, which is not a perfect windshield. All right? Now, just for explanation's sake, even though there are so many techniques that I've designed and pioneered, let's keep it very simple for understanding. Let's look at only 2 structures in your eyeball. The cornea, which is a keratoconus, and the lens of your eye. The normal lens, which is a crystalline lens, which is crystal clear and soft in a normal patient. With age, it becomes a cataract, cloudy. All right? Just let's keep it back there and let's summarize again. Visual, structural, salvage categories. Your cornea is a cone and your lens in the eye, which everybody has. Now, how do I approach these cases? If the cornea is visual keratoconus, you can see with glasses. That means I have visual techniques to perform on these cases. First, in every keratoconus patient before I operate, I do want to ensure that y'all are measurable and stable. Remember, you can't operate on a keratoconus that's changing. So young patients, you don't want to. If they're less than 20, you want to constantly make sure they are stable. Those are the only patients I approve for having cross-linking, wherever they're having it. Because just cross-linking your keratoconus cornea, let me take you into this explanation for a moment so you'll understand this. Let's forget this for a moment. Let's just focus on your cornea. I'll draw it out for you here. So your cornea, which is dome-shaped, let's accept it as cone-shaped, okay? Your cornea. Now, I make this analogy to the human spine, our back. Let's say our back is bent instead of being straight. All right? Keratoconus is a bent back. All right? It's a D-shaped herniated cornea. By just cross-linking it, let's make cross-linking blue for whatever it's worth, the color. By just putting cement on it, which is firming it up, yes, you're stopping the progression of the cone, but you have left it in a crooked position. So your vision isn't helped. Just think about this. I call this the keratoscoliosis concept, meaning just because the back is bending, you can't just put cement on it and say it won't bend anymore. Sure, great, it won't bend anymore, but why won't you straighten it first and then put cement? Getting my point? So I like to always straighten the cornea and then, if required, you can always cross-link. And our technique of cross-linking, which is painless, that we've been doing on patients now for decades, and how to do that, different discussion later. So cross-linking takes minutes to do. There are protocols that we follow, and it can be safely done with no pain, and you're done, but how to do it and when to do it. A problem I have is a lot of patients come to me already cross-linked, and now they are lost. They were cross-linked and told that their keratoconus won't progress anymore. Yes, correct. What about vision? Now forever, they have a bent cornea that has been cross-linked and they're left like that. And it becomes a little more difficult for me because I have to now shape that cornea against that cement. Think about it, right? I would rather have a virgin keratoconus that I can predict and work on. So that's the part of cross-linking that I'd like to explain. Now let's come back to how I address these cases. So if you're a visual case, there are techniques I do with laser, surface laser, never LASIK or smile on keratoconus, no cutting procedure, no astigmatic cuts, nothing. Laser procedure. I have defined these techniques not for patients, but more for eye surgeons into super specialties of refractive surgery called laserplastic, corneoplastic, lensoplastic. None of these are procedures for which I want you to fly based on their name because we don't advertise. But this is more important from teaching point of view. For you, it's a laser procedure done on your irregular keratoconus, all right? Removing minimal tissue using a proprietary algorithm to increase your optical zone, flatten your cone. This is your cone. When the laser acts on it with laserplastic, all right, painlessly, within seconds, it flattens your cornea, makes it more regular, removes very little tissue, and improves your optical zone all in one shot. No chance of dryness with it. All of those are concepts of laser plastics. Very, very important to me. So that's a visual surgery straight to vision. If you are high myopic, very nearsighted with astigmatism but can see with glasses. Remember I told you we are talking about visual category, meaning you can see with glasses. If you're very, very nearsighted with keratoconus, then I put in an ICL over your natural lens. That's your natural lens. I will put in an ICL on top of your lens. It's an internal columnar lens, basically like a contact lens being kept in your eye on top of your natural lens. It takes literally minutes to do under topical drops, and you're done, and it has a tremendous visual value, and we have avoided your cornea. Remember, if you're too nearsighted, I don't want to laser too much of your cornea, which is already thin. So you put in an ICL. This ICL now, the later versions can also correct astigmatism. All right, it's called a toric ICL. So that can be done. I can do combinations of laserplastic with ICL. Now, let's make you 58 years and above, older. Instead of putting ICL, I would rather go inside your eye, remove your early cataract. Cloudy lens. Remember, everybody who lives long enough will have a cataract. Remove that, put in a special lens in the bag of that, just like a cataract surgery, but based on principles that I call lensoplastic, that is based on irregular corneas, and fix your vision or your cone. Are you with me? So for visual cases, we can do laserplastic, ICL technique, lensoplastic based lens and cataract surgeries, because all these are accurate surgeries to take you straight to vision. And also I can combine in cases, let's say you're very nearsighted and have high astigmatism and are still visual, I can do ICL with laserplastic. Let's say you're cataract age, I can do lensoplastic based cataract surgery and then do laser on your cornea. So combinations are possible. It's just how safely it can be done and how it can be taken to all your corrections. Now let's go to the next category. So we discussed visual. Now we'll go to structural. Visual is done. Everyone clear? Structural. Structural is when you can see with specialty contact lenses but not with glasses. That's how advanced your cone is. In those cases, I need to structurally modify your cornea. Okay? So I will do intracorneal implants. So if you look at the cornea and cross section, I will put in an intracorneal implant like Intacs or Cares or Cara Naturals, any of these products. In your different countries, they also have Ferrara rings, Cara ring. I'm okay with any of that. All right? With my international privileges, all of these are aspects that we can perform and do. But this is what I want. I want in the cornea a brace, rings that enter the cornea in the corneal tissue. So it makes that steep cornea flatter, stretches it, and actually makes it stronger because like braces in the cornea. So I have structurally modified your cornea. Now, in these cases, I'm not done yet. In majority of our patients, after they have had their structural surgery, I wait for 3 to 6 months and see, are they getting visual? If they become visual from there, I can again go back to my visual category and do laserplastic, ICL, or lensoplastic based surgery. Does that make sense now? So I'm structurally first fixing the cornea and then coming back and getting the vision, because I'm always driven by vision. I just want you to see. And if you can't see without glasses and contacts, that's my dream for each one of you. The fight is in that direction. Now let's go to salvage category. Now in structural, there's one more thing I want to add, which I already taught you about cross-linking. After having done the surgery, after having done visual, you can still cross-link if needed. If needed. And then that's a proper pattern because you've corrected the cone and the vision, and now you're permanizing it with the cement. Are you with me? Excellent. So now we go to salvage. Salvage is where your cornea has become so thin, so scarred, unmeasurable, doesn't have structural capacity, it's absolutely not visual, and you're left with no options. Still, I will not do a full transplant for you. In your cornea, even though it's so thin, I do what is called a hand lamellar compression keratoplasty. So instead of removing your full cornea and doing a routine transplant, which is violating the interior of your eye, then having 16 stitches, years of rehab, and finally problems of rejections, poor vision, and hard contact lens, I do a hand lamellar surgery, but even in your thin cornea, I very gently dissect with my techniques and technology, and I then replace a donor cornea that is much more thicker on top. All right, so I removed 2 layers of turkey slices, but I put 4 layers on top. So I added thickness to your keratoconus, removed the scar, and made that 100 microns into now 480, 490 microns. Now I have built you up, built your foundation. That surgery takes about 15 to 20 minutes and can be done. It's difficult but possible. Now that I've recreated your cornea, I can now go back, and again, what am I trying to always do? Go back to visual. Laserplastic, ICL, lensoplastic, or combinations. So you see, every time, no matter how complex you are, I'm always thinking about vision, how to give you freedom. Now, let's take you, among the categories you saw everything, now let's take into consideration you've had surgery somewhere else. Let's say you had cross-linking. Nothing wrong with it, but you saw my philosophy. I don't like it to be done before the keratoconus is fixed to vision, okay? Now, you may have had cross-linking done. You may have had laser surgery done. Some people do scraping for scars. You may have corneal transplants done like DALK or full thickness transplants. You may even have had cataract surgery. Even if you have had all these surgeries, I'm not bothered by it. It just makes my work more difficult, but I'm not bothered. Why? I still take you and put you into the categories: visual, structural, salvage. And I'm constantly looking for vision potential. So after all these surgeries, no matter where you had, in which country and which surgeon or what technology, I just want to know where you fall here. Right? That's what I fight for every time with all of you. Once I see where you are, again, my pattern is vision. So if you are visual, after all these surgeries, I take you straight to vision. Laser, ICL, lensoplasty. Correct? And then if you're structural, I build your structure. I'll put an intact ring or Kehr's ring or Keranatural or Ferrara or, various patients come to me with various rings. They have the Anhegio ring from South America. I just had a patient which I fixed. And of course, the Kera rings and all this. So, structural. Let's say you've had these surgeries that are completely damaged. Cornea is completely gone. Again, hand lamellar, keratoplasty. You can always have a full thickness transplant. It's my desire to always resist that in any of you as the last resort, right? So that's something you want to avoid as much as. Nothing wrong with it. I'm just visual. I just want vision all the time. So now, you understood this. You also understand combinations. So there is no limits. I call it no limits, right? Because you can combine visual cases with structural. You can take salvage cases and combine, and various combinations now. Various laser techniques I can do with lasers, different lasers on the cornea. ICL, toric ICL, cataract surgery with monofocal, toric meaning astigmatism for focused monofocal lens, even X-wave technologies, various lens technologies that I've used over decades in patients with cataract and keratoconus. It's possible. And even if you've had previous surgeries on the cornea, you can still have a successful cataract surgery or ICL surgery, right? So having keratoconus is absolutely not the end of your life or career. I want you to understand that there are different custom design techniques and technologies for you. And please do not fall for any gimmicks. Please appreciate every doctor who's trying to help you and do your due diligence. Ask to see patients. I don't think any doctor can or should guarantee the outcomes for keratoconus patients because yes, these are abnormal eyes. But I want every doctor to guarantee their fight for you. I want them to dream about your vision without glasses and contacts. If you land with glasses and contacts despite surgery, no big deal. But at least surgically you are now stable and done. And the residual is covered with a special contact lens or glasses. So understand this. Just wearing a contact lens on an advanced keratoconus, of course you will see, whether it's a scleral contact, hard contact lens, 3D print contact lens. And a tremendous respect for optometrists and eye doctors who are doing that. But here's the caveat. It is not the cure. You take a fractured leg that is bent and you give a patient a crutch to walk with. Yes, you can walk with a crutch, but that fracture, that break, that bend is getting worse underneath the crutch. So you come to a stage by the time you come to me having worn a contact lens for 10 years. Now you're scarred and very bad keratoconus. You were visual, but now you became structural, which is horrible. Clear? Similarly, you just had cross-linking and then nothing has been done for your vision. You wait and wait and wait and wait with contact lenses. So again, guys, all these modalities are useful. Contact lenses, cross-linking, transplants. But if you follow this concept with which I have treated patients from all over the planet for 3 decades, and we have shared their stories on our YouTube channel. Again, we don't advertise, it's just to inspire our profession. And I want to make sure that you don't get depressed. Do not think that you have only 3 options and actually ask for vision. So if you have keratoconus, do not worry. Take the next step, do your due diligence, and we are here to help you. For more knowledge you want, our website is literally an encyclopedia. Again, there are no deals, there is no advertising here. You don't have to come to me. I encourage your doctors, as I keep teaching all over the world, to do these techniques. Safety first, follow through, make a long-term plan for each one of you and put you back into your lives, into your personal and professional lives. So any questions, you know where to find me, Dr. Gulani, our website, of course, GulaniVision.com, our YouTube channel, GulaniVision. Just go there, immerse yourself in the knowledge and call with any questions. All right, for your eyes, Dr. Gulani.